the chair shall remind the members of their duty to avoid conflicts and appearances of conflict and inquire as to whether there is any known conflict of interest or any appearance of conflict with respect to any matters coming before this board. Individual members must make a diligent effort before taking any action, including participation in discussion, to determine whether a conflict or appearance of conflict exists. Individual members have an affirmative duty to inquire of their business associates, families, and close friends of any issues that may come before this board. If a member has a question regarding his or her particular situation, that member should ask direction from the chair, or in the event of the chair's unavailability, the vice chair. Does any member of this board have any conflict of interest that needs to be reported? Hearing none, I think we can proceed. Kathy?
The first or the next item on the agenda is to approve the minutes. Sorry, got to get there. From the September, I'm sorry, the March 2021 meeting. And
so I move to accept the minutes.
I second.
The minutes have been accepted. Motion has been made and seconded to accept minutes from the December 9th meeting. All those in favor, please let it be known by saying aye.
Aye.
Aye. Those opposed? Hearing none, the motion carries.
very good. Thank you. We will do the closed session minutes during the closed session. We have two applications to review this morning. The first one is Lorna Lucaton, and she is an endorsement candidate from Tennessee who was foreign trained, and she actually, when she submitted her credentials review, it was a credentials review that I had the ability to tell her what she could do. Her general education and humanities can be CLEPT, and the professional education, we had some resources that we could send her to complete. She's completed the professional education, but she has not yet been able to complete the CLEPT. So we still needed to, my recommendation is that she be considered eligible for licensure once she completes the requirements that are missing in her educational credentials review.
So she have that much more left once she take
one CLEP, one humanities CLEP course, and that's it. You know, so it's an online test that she needs to take and pass. And this person has been exceptionally efficient about asking questions, completing what she needed to do, and she's got a lot of years of experience. So I think you know, I don't have any reservations about that in any way.
I move we accept the ED's recommendation.
I'll second that.
Motion's been made and seconded to accept the ED's recommendation on this applicant. All those in favor, let it be known by saying aye.
Aye.
Aye. All those opposed? Hearing none, the motion carries. The next applicant, Kathy.
This is Rajveer Chahal. She also was educated outside the United States. Her credentials review from IERF shows, as you can see kind of on the documentation I've got in ClickUp, she has a lot of educational deficiencies, and I recommend that she be eligible for licensure once she makes up these educational deficits. But I think she's going to have to go to something like FCCBT and plan to get somebody to help her figure out what she can do, because I just don't have the resources to be able to tell her all of these things that she needs to make up. The program that she attended just must not have had, the same level of requirement. In fact, I think it's a bachelor's degree in India, and I think that she's got more work to do. But if she does it, I think she should be made eligible for potential licensure once she completes it, or at least made eligible to take the exam. I'm sorry, she is an exam candidate. So if she meets all of our requirements, I would recommend that she be able to take the exam.
Do we need a motion on that, or do we just need to?
No, you need a motion.
Okay.
Motion to accept the ED's recommendations for this candidate.
A second.
Motion's been made and seconded. Any discussion? No. Then all those in favor of the ED's recommendation on this particular candidate, please let it be known by saying aye.
Aye.
Aye. All those opposed, no. Hearing none, the motion carries. Kathy?
Okay. We have one item of business that is actually a historical board policy. And back in December, I was communicating with Jamie Nolan, who is, I think, the assistant director of FCCPT, about physics, because typically that's one of the general education courses that people are missing. And so she told me that FCCPT had changed their policy back in 2009. So we're a little behind on that. And if someone has some knowledge about CLEP, feel free to jump in. But my understanding now is that because there are programs available that offer online courses that include a lab, how you do a lab online, I'm not exactly sure, but there are courses that offer it for both chemistry and physics. And the board historically was accepting natural sciences as the CLEP exam that met the requirement for chemistry and physics. But when you look at the CLEP, what the CLEP covers, very, very little chemistry and almost no physics. So I feel like, we ought to be working towards the requirements that will most or best serve an exam applicant on the exam. So there are other ways to meet that requirement. So I am making a recommendation that we change the board policy to include the updated recommendations from FCCPT to be able to meet that educational deficit.
And basically that just puts us in line with FCCPT.
Correct.
So do you have a draft of the policy, proposed policy?
So if you go to that's not the right one. It's the Word doc that's in your.
Okay. Got it.
It says it was adopted in September of 2005.
Well, our current policy was adopted in 2005. What we didn't know was that FCCPT changed their, and in 2005, we were aligned with FCCPT. In 2009, FCCPT changed their policy. And so it just happened that I was trying to assist someone with their educational deficiencies and how they might need it. And so I was communicating with Jamie Nolan, and she told me that they had updated their policies, and she told me how someone could go about it. So I'm proposing that we rescind using natural sciences to fulfill physics and chemistry requirements, and to fulfill it by taking either virtual or live physics or chemistry courses from regionally accredited schools, just like you have to for other things, because now they're available in a more easily accessible means. Previously, you had to go to a university to take them, and now if you can do it online, it's more relevant. Physics clearly is more relevant to physical therapy practice than the natural sciences are. So at the last paragraph in that policy, if you'll look at the Word document that I have attached to the agenda is what I'm recommending.
Mhm. Has everybody reviewed both the old policy and the new Word document that Kathy submitted?
Yes.
Okay. Do I hear a motion?
I'll motion to accept the proposed policy change as recommended by the executive director.
I'll second that.
Motion's been made and seconded to adopt this new policy. Is there any further discussion or question? Hearing none, we'll take a vote on this. Everyone who's in favor, please let it be known by saying aye.
Aye.
Aye. All those
Aye.
opposed? Hearing none, the motion carries. Kathy?
Thank you. And we are up to the attorney's report. So this would be David Gadd.
Thank you. So one thing I'll ask real quick, Teresa and Kathy, would it be helpful to, you mentioned a minute ago, there are some things on the agenda that you might want to accomplish while it's early and you're fresh. Would it be helpful to bump item E on the agenda to the afternoon? I don't mind, and that might accomplish what you were trying to do. It's fine.
So David Gadd is offering to reorder the agenda items, postponing the attorney's report to the afternoon and bumping up some more critical agenda items to the morning. Is that okay with everybody?
Yvonne?
Agreed.
Thank you,
Yes.
David, for making that offer. Kathy, go ahead.
Great. Okay. So then why don't we scroll down in your agenda to item B, which is scope of practice questions. And we'll start with the peer review framework that we discussed at the last meeting. And we're on part 2 of that. It was,
Kathy, can I interrupt you just a moment?
sure,
So which letter are you suggesting?
B. So if you go to if you scroll down and click up to V, where it says scope of practice for board consideration.
And for anyone that's listening online, that's V as in victory of the agenda.
Ah, yes. So we are looking at the very first item under that, which is peer review. And the framework for reviewing scope of practice questions. And at the last agenda, we approved this conceptually. And now it's more about so how do you use it? How would you use this in order for a board member preparing for a meeting? How would you use it to make an analysis for yourself about whether something is within the scope of practice or not? So I combined part 1 and part 2 in the document that's attached. And if you scroll down to where it says part 2, there's kind of a step-by-step of how we might, as a board, use this peer review tool to analyze scope of practice questions that are asked. So the way that it works is a question comes into the board office and either it's never been answered before or it's been answered previously, but it appears as though it may be dated in terms of the response that we have previously provided. And so as a result of that, I consult with the board attorney and we decide whether we should add that to the agenda. So once we decide we're going to add it to the agenda, then we have to provide some information to board members to look at. And if you go back up to that nice graphic that Debbie Reagan created, the things that we're looking at are education and training. Where's it taught in entry level? Where's it taught in continuing education? Where is it routinely performed in practice? What's the evidence for it? And what are the risks to the public? And, you know, you'll hear me say this probably more times today than typical, but our role is in public protection. And so an analysis of risk as it relates to scope of practice, number one, helps us make a determination about whether, you know, the entry level education and current level of practice are, it's a safe activity for PTs that have, or PTAs that have the competence to do it, that we could approve that for the public, or if it's an advanced level skill, are there other things that we need to do in addition to just saying, yes, it's part of the PT scope of practice? We may need to implement some rules that require a certain level of training by an individual or a certain level of supervision be maintained while a licensee is performing those activities. So the board staff does that research. Sometimes we have to bring in experts to the meeting in order to assist in that discussion, because while certainly Debbie and I are licensees, you know, some of these emerging types of techniques or machines are not things that she and I have ever performed in practice or have education about. So we need to supplement with that. So we provide you these materials as part of the ClickUp as you prepare for the meeting. And so when I draw your attention to the areas that need discussion or that need a motion, those are the critical ones you really need to read all of the information about and form an analysis, or, you know, your own personal analysis. And then also, if you have questions ahead of the meeting, we're very glad to answer those questions or say, oh my gosh, we don't have that information. We need some more information about X. So as you go through it, you need to kind of self-answer the question. Is this currently performed in practice? Is it performed in entry-level education? And is it available widely in continuing education? Or is there evidence to support that this is a safe and effective technique to be used with patient care? And then what is the level of risk to the public when it's being used? And so because that risk question hasn't been as frequently addressed in a, how shall I say, a more objective, measurable way during our meetings. Further down here, I'll show you what type of rubric we've created to help you think through that. So, you know, and then are there any other questions that you need answered in order to help formulate your analysis? And you will let the staff know that, or we can discuss it at the meeting. Then, as you're looking at this, if you scroll to the tables at the bottom, you can determine, so from the information that we provided you, how often is it seen in practice? You know, is it just someone that's got a specialty that learned it in Europe and they brought it over here and they happen to be practicing it here? Or is it something that is very routine? You're aware of it in many settings, and you know, there's evidence for that. You know, so you can read how you would rank it. But if you look over on the chart that says peer ranking number, you're also looking at, are we able to provide you information about evidence? You know, so what kinds of evidence have we been able to provide you? You know, is it an opinion paper in a journal, or is it a random controlled study? And then in regulation, what is the risk that you believe that you understand from reading these documents? Is there significant risk? Is it an invasive technique that requires significant additional training and practice, and not just didactic, but hands-on training? And, you know, how much additional training would it require? So, you know, that would be higher on the scale than no additional training is necessary, because all that's taught in entry-level education, and, you know, you're getting enough in your clinicals that you could be deemed competent to perform it. Then lastly, you add up all of the numbers that you obtain from each of these columns, and you look at where it falls on the scale. Is it a low risk activity? Is it a medium risk? Is it a higher risk? And then those are the things that we want to discuss at the board meeting. And that helps us determine if it is within the scope of practice. Are there additional requirements that need to be determined before someone can practice it? So this item on the agenda is more about, this is the framework that you approved last time. This is how we're suggesting that you might go about using it. All by itself, it's not the only thing you can use. You might request other things that the board staff could prepare for you so that you could analyze this. But I think what I'm asking for in this agenda item is, your feedback on it. Do you have questions? Is it something that you would want to move forward with since we've created it? And that allows you the ability to be consistent. And we have a very transparent method of looking at scope of practice questions that complies with our regulation and helps us better analyze risk, and then to determine whether other things are necessary as part of public protection. So anyone have any thoughts they want to offer? Anybody disagree with this or would like to see something in addition?
I think it's a great document, and it gives the solid foundation, the validation, like these are the steps we take. This is the procedure we take. It's easy to follow through for every person and for when members of the board change, so that everybody's using the same process.
Thank you.
Yeah, my compliments for a job well done on this. It's very well thought out and put together.
Thank you. Thank you. It was a team effort. Debbie and I worked on this and with David Gadd, and so team effort. Your board staff is working together to try to help do this.
I agree. It's well done and useful. I was just thinking in my head about like questions like, can PTs administer the COVID vaccine? And I was trying to take that through the rubric in my head, and it's not, it's not taught in practice. I mean, in schools or anything like that. But there's a very viable reason that, especially in some communities, PT may be a great person to administer that. And a lot of people of different disciplines and not of any discipline have been trained to administer these vaccines. So I was just trying to take it through in my head, how would that one fit in there? So is that one that's not really a scope of practice? It's okay to do as long as you say, I'm a PT, but this is not a PT practice?
Yes, yes. And that was what you as a board decided.
So we said that, but say we had that discussion because there are several states that adopted like PTs can be part of the group that's administering the vaccine, and because you're not acting as a PT when you're doing that.
But, so those questions, how would we address that in here?
Well,
it would be a no all the way across.
It would be, but
Right.
if someone, so you can say right away, it's not in the PT scope of practice legally. However, if you obtain the necessary training and education to perform it, which was available and still is available, and if there are other state laws that govern it, and in this case, it's medicine and pharmacy, if you comply with those other laws, then you can do it. And I think the practical reality of administering vaccinations, I don't really know how many PTs actually did it, but they were supervised and they did get the training. And this, I'm thinking more about rural areas. And I got a lot of questions really early on from education programs that were in more rural areas that the local health departments trying to leverage their health education students to do these vaccinations. So it was my understanding that they were going to be supervised and trained in how to do it. The only part is it's still not in the PT scope, but it wasn't that you can't do it. You're just not doing PT, just like you said,
Right.
Leslie.
Yeah, I really appreciate having a standard rubric for the scope of practice questions we've had. I think this will make it much easier for new board members coming on to have a better foundation for making these decisions. And I really appreciate the work that went into pulling all this together. And from a peer review perspective, this is what we've needed for a long time.
Yeah, and I think probably we have been doing it in a similar way. It wasn't as clearly written down and articulated. So I think here at least the board has this, and like you said, from training new members and that sort of thing, helps you learn to be able to how we think about it and what is legally or regulatorily appropriate. Okay, so I'm going to take that as we'll continue to use this methodology going forward until the board decides to change it or we need to refine it further. So
we need to adopt this as a board policy or board procedure.
David, what would you say about that?
I don't think you need a formal motion for it. I think the board can just, you as a board have looked at it and reviewed it and informally approve it as just a tool to use to assess incoming questions.
Okay.
So I just don't think a formal, we're not taking any formal action. It's just a tool, an additional tool that the board can use to assess these things. So I don't think it's necessary.
Thank you. So dovetailing onto peer review, I'm going to move to the next item, which is public protection, potential risk and harm in physical therapy practice. And I have become aware of, through the complaint process, through other questions that I'm getting, just on a routine basis to the executive director, through listening to some of these FSBPT seminars, the Dale Atkinson one on scope of practice, expansion of scope of practice specifically, and then through the PT Compact, that there are some areas of physical therapy practice that seem to be more frequently either being reported as complaints or asked about, or seemingly there may be more potential for a practitioner who might be impaired or not qualified to be out there practicing that we're not aware of because we don't have a rule or process in place to address it. And so I would like to recommend to the board that we establish a task force and that we look at some of these very frequently occurring things, such as complaints that involve dry needling, sexual boundary violations, issues of informed consent, substance use disorders, and reporting of convictions in between renewal times, so that we are better aware of the status of our licensee population and whether further action needs to be taken, but also looking at whether we need some additional rules in place with some of our advanced techniques so that we are giving the public some level of assurance that when they see a PT practitioner, that what will be used and what will be done will be safe and effective. And so I don't know if that's enough of an introduction. Certainly I'm open to questions and can provide you any information that you'd like to consider this idea of a task force to consider some of these questions. It may result in us feeling that this peer review tool is effective for scope of practice questions, or it may result in the need for more rules. And the task force can stay in place as long as we feel it's necessary to respond to some of these things that are coming up. And we can always either make it a formal committee, should we feel like it needs to be in place in an ongoing manner, or it can be disbanded, when we feel like its usefulness has happened. One of the other things that I didn't mention is that we are getting more and more scope of practice questions that are more and more complex and beyond, Debbie's and my educational background, or it's emerging technology that you can't find information about. And we need a group in between board meetings that's got more time to consider some of these things and obtain information about it, and further discuss it, so that those recommendations can be brought to the board. Because I don't think at board meetings, we've got one day and we don't always have as much time as we need for every single one of these questions. And as you can see today, I ended up with a lot of questions for this particular meeting.
Mhm.
So, all right. So that was what I wanted to say.
Personally, I think it's an excellent idea. Our practice is very diverse, and I would like to think stays in the forefront of new things. And so I could see where I could be potentially helpful with this.
Anybody else? Thoughts, concerns? Don't feel like we need it.
I support it as well, and
Yeah.
I'm interested as well.
I think it would be beneficial.
And
Do we have
I definitely think we need it.
Yeah.
Kathy, do you have a budget item for this creation of this task force?
I do. And I believe, now that we have all of our technology in place, the last task force that we had was on supervised clinical practice for foreign educated applicants seeking licensure. And the board utilized some foreign trained licensees, some companies that employ foreign trained applicants, some board members, some staff. And we ended up having to meet at a central location at a hotel, which was pretty expensive. Now we have the ability to do some of this work online in a Zoom meeting, and some of this work we can do. We now have a board office and a conference room. We can also do it that way too. So I believe I put in about $6,000 for that, because certainly board members that participate, they'll be getting a per diem and their expenses. And then we would involve subject matter experts and anyone else we feel is appropriate to this process. So
So Kathy, how many do you think you need for that task force?
a really good question, Pearl. And I think what in the memo that I provided for your review, what I said was that the executive director, deputy director, and attorney are going to make some further definitions and of the group, set some meetings, develop the agendas, et cetera. I think, I'm thinking between like 5 and 7 members, you get too many people and it becomes hard to even set up a meeting just because everybody's schedule is too different.
Mhm.
I think, you have, maybe 5 to 6 core members, and then you invite in the subject matter experts for particular meetings. And,
For whichever topic is there.
Yeah. So I think what we would want to do today is determine if a board member would be willing to chair this task force. You'd be supported by the board staff and the attorney. We'd be doing the legwork to provide all the materials for you and gather the information and organize the meetings and the people. But I think it would be appropriate to have a chair for this task force from the board.
If I can chime in as well,
Yes.
one thing we'll need to consider is if there are a majority of this board, the majority of the members on this task force, then those would be considered official meetings of the PT board, which would require open meetings law notices and that sort of thing. So I think we probably want to keep it under the majority of the board so it can function more like a committee rather than an official meeting.
Thank you. First thing I think we have to do is make the motion, and at the bottom of the memo that I prepared for you is the motion, and it says ex-board member makes the motion to approve the board establishing a public protection committee to research specific issues in physical therapy practice posing risks and harm to the public, and make recommendation to the board recommending minimum practice standards and license competence requirements.
And one question, David Gadd, is there any difference between calling this a task force or a public protection committee?
Oh, whoops, that was my bad. That's I meant a task force. So sorry.
Okay.
Legally, no. You can term it any way you like.
Okay.
So I would make the recommendation for a board task force for public protection as a public protection. Is that the right way to put it?
Yes, I
Public
think
protection.
Okay.
Yeah.
I'll second that.
Okay, the motion has been made by Pearl Roan, seconded by Crystal Osland to approve the board establishing a public protection task force to research specific issues in physical therapy practice posing risks and harm to the public, and to make recommendations to the board recommending minimum practice standards and license competence requirements. Is there any further discussion or questions about this motion? Hearing none, we'll put it to the vote. All those in favor of this motion, please let it be known by saying aye.
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 All those opposed, no. Anyone abstaining from this vote? Hearing none, the motion carries. Kathy?
so. At this point, if there is anybody who's interested in throwing their name in the ring for chairing the committee, we could talk about that. Otherwise, the staff can work on that in between meetings.
But Kathy, what we're looking at here is when a more challenging question comes up, that this task force would dig into it and provide recommendations, basically.
Correct.
Okay.
Correct.
I would be willing to chair it.
Okay. Anybody else interested?
I support David.
And I second.
Thank you, David. We're all appreciative of you accepting this challenge,
You're welcome.
because I think there are a lot of issues that need to be addressed as quickly as we can put this task force together, coming out of investigative committee. So that's great. Thank you, David.
Thank you.
Now, is anybody else interested in participating on the committee so that we don't forget to ask that question here?
Yeah, I am.
I would be willing to.
And who was that?
Jamie and Crystal.
Willing, but I appreciate what David said about the size of it. So whatever you need, just ask.
Yeah.
Excellent. Thank you. Thank you. Okay, so we will be getting back to you after this meeting regarding getting that set up. The next scope of practice issue, we will, it was scheduled to be tentative. I've had several questions about shockwave therapy in the last 2 weeks, and I can never get anybody to tell me specifically what it is that the machine is doing. I can't get a name. I can't get any machine specs. I can't get what it treats. And I mean, I can Google it and I do, but it's, you know, I can't get it. So we're not going to address that today because I didn't get any follow-up from anybody. And we've talked about this sort of in a roundabout way more than once. And I think we've ended up deciding that it can't be part of the scope of practice if nobody can really say what it is or what it's doing. So that's where we stand so far.
Hey, Kathy, is that kind of
sorry.
like the old timey weight loss machines with the belt that vibrates?
Well, I don't know. I can't tell whether it's using sound or electricity or what it is that they're talking about. So yeah, I don't know, but maybe in that vein.
What's funny is we all know exactly what David's talking about.
We do. We're all old enough to have seen those.
And I've seen it come back.
Maybe David Gadd isn't, but I think
there is a business in Greenville that does a lot of alternative medicine, not PTs, but it's this platform that you stand on and it vibrates you. And they claim all these benefits to it. So I'm just thinking, oh, maybe this is what it's referring to.
Does it vibrate you away from the kitchen table?
That would probably be about the only way it would work.
Yeah.
Well, and I think this is another example that needs to be referred to our new task force, because if you've attended any APTA meeting or CSM or FBPT meeting in the last 3 or 4 years, there are exhibitors at all of these meetings who have all kinds of therapy machines and materials. They're trying to sell these pieces of equipment to PTs, but they have not been vetted as scope of practice questions. So I think it's just another great example of why we need this task force.
And I think they're not talking about lithotripsy or vibration. They're talking about a new device that's basically a modality combined with laser that does ultrasonic shock waves.
Yeah. And that's why I really wanted more information specifically from the question asker. And if they're not able to articulate it, I think we don't even really have a place to start. So
I agree.
So we will pass that question today.
And Kathy, I have a question.
Yes.
I would like to be part of the task force, if that's okay with you guys, but kind of since I'm the one need to learn the most, I think that'll be beneficial. I'll be the helper of the helper of the helper of the helper, the elf of all of you, because I would like to learn all the machines that are used. And I know that some people combine, like I seen just one guy that combines kind of oriental training like acupuncture and cupping and also kind of chiropractor practice, and also the PT and EASE. I thought that was great, but I need to know in our state if all that works and is regulated. I think it's fantastic to combine all those knowledge, but I wonder if that is, as I say, I'm the one knows the less, and I need to kind of get on that.
I understand. Okay, thank you for offering that. And I've got your name down here.
Thank you.
So imaging, we're going to revisit at 2:00. So the next item under scope of practice is the CAPD and call for response. Did anyone happen to be able to listen to the CAPD presentation at FSBPT yesterday?
Yeah, I did.
Okay, well, I was not able to, and I'll have to circle back around to it when they've got the recording out. But so Jamie, if you have anything specific to offer, please jump in. Every 5 years, CAPD asks for input on the curriculum of entry-level practice. And, you know, typically it's a big, broad, huge bucket. And I sort of have felt like from a regulatory point of view, that hasn't always been what is, directly specific to us. But this year, I've become aware of the fact that CAPTE curriculum does not have informed consent in it. And so I would like to propose to the board that we send in a recommendation. They don't have to take it, but that they create an item in the CAPTE curriculum for informed consent.
Absolutely.
And Kathy, what's your rationale for wanting to include that?
One of the issues that has come up at the investigative committee that we do not have specific law or regulation for in North Carolina is surrounding informed consent with techniques for physical therapy specifically, and some invasive techniques. And, I believe that this is, number one, there's an item in the Model Practice Act for patients should be informed. Part two, I think in APTA and the Guide to PT Practice, the patient is a part of the plan of care development. And, the patient does need to know and understand what they're receiving and whether they agree to it. And, as we all know, various techniques that physical therapists use, have contraindications to them. And you need to understand that by asking the patient and obtaining their consent for it, and not just a blanket. So I believe that this is helpful, and it may also stimulate, if it goes to our subcommittee, it would be useful to know whether we should also adopt some rules that relate to that.
Okay, thank you. Any other question for Kathy about this? And Kathy, would you be the one to respond back to CAPTE?
I would.
And Jamie, did you have any insight from listening to the discussion yesterday, the webinar?
No, their main thing was how they operate and what they look at when approving schools and PT and PTA programs, and what can get a school into trouble and that sort of thing.
Okay. And do we need a motion for this, Kathy, or you're just going to handle that as the ED?
I think I would just handle it, David, unless you think we need a motion.
I agree. You can just handle it.
All right, thank you. Great.
Okay.
Next question.
DPI.
Yeah, so this is more of an FYI. For those of you who are involved in pediatric physical therapy care and school-age kids, the Department of Public Instruction has come out with some guidance for PTOT and speech language pathologists that your frequency of care can either be every single day or once a week, period. Those are your options. And so I received information from a couple of licensees about this, being concerned that maybe this is taking away the ability of the licensee to make an assessment and a determination of a plan of care. David Gadd and I are meeting with DPI representatives, a couple of PTs, some OT board representatives. We invited the speech language pathology board, and they didn't feel like it was within their purview so I don't think they're coming. But I think we're trying to get a handle on the issue, why this policy was implemented. Does it interfere with the Practice Act or not for licensees, and what the issues are. So this is just more of an FYI that we're participating in that as a result of a question that was asked.
Yeah, it's creating quite a bit of a stir. There's a lot of backlash, and I understand, although Perry Flynn hasn't said it directly, he doesn't support it, is the kind of consensus, but it does create potential scheduling and delivery, therapy delivery problems.
So who came up with this policy? Who put it in place? Department of Public Instruction?
Correct.
Which
Who's
is an
Terry Flynn?
education.
Perry Flynn's a consultant, longtime consultant. He mainly focuses on speech. He's an excellent resource, but he has very deep knowledge about that. You could reach him at UNCG's Communication and Science Disorders Department.
Thank you. Did someone else have a question?
Is that under like the Department of Education? Is that a state or a federal?
This is state.
State.
Yeah, I would have some concerns about them dictating the frequency. That seems to me part of the PT's role or whichever therapist.
Yeah.
It does create some practice act issues in my mind.
Okay, so, I don't know whether this will come back around or what, but we're having a meeting on the 11th.
Okay, that's good.
The next thing on the item on the agenda is regarding our position statement, number 7, the physical therapist's role in managing and recording medications. So as I was saying to someone before the meeting, things tend to come in threes to my email box. And this is one of those things in the last month that I've gotten in threes, and it is physical therapist assistants asking, or their supervisors or corporates asking about what physical therapist assistants can do. And I think where we're getting hung up probably has something to do with payer policy. And, because that's not in our purview, I am not as familiar with that. And you all may be more familiar with that than I am. But, the whole term medication reconciliation, well, it's my understanding that, in some worlds, PTs are not really the people to be doing medication reconciliation. We don't have that primary education. We don't prescribe medication. Your role is to understand what a patient is on, what the effects may be on an individual while you're performing your treatment, and how that might affect somebody, and how to recognize if something is happening, so that you can address it. So the board has a position statement, and you may want to pull that up. It's in your ClickUp. And so I think this is primarily coming from the home health realm. And, when a PT goes in, my understanding is you need to check that the list of medications that you have is the same medication that the patient is taking. And, if the patient has any questions, you need to refer that to either the nurse that's involved with the care or the physician. And then, the information should come back down to the patient from that healthcare provider. The PT is not supposed to talk to the patient about anything other than what is information that's out there in the public domain, or to be able to say, yes, your doctor prescribed that for you, and that's for your blood pressure. Now, when you get to a PTA, it's a little different. My understanding is that the PTA can and should, again, check that they're taking those medications, or that they have those medications, and maybe just ask for a subjective report of, are you taking them? But the questions that I'm getting are surrounding whether a PTA can hand someone basically like the leaflet out of the medication box, because they have it. Now there are electronic medical record systems that if somebody's taking this medication, it can pop up information about that. And can the PTA provide that to the patient? Well, some PTAs are saying they're being asked to teach the patient about medications, which I would believe is outside of the PTA scope. And so what I don't think we have enough clarity in our position statement about is about that teaching, and then specifically about PTAs and what they can give to a patient regarding medication. So I need some more help with this. Debbie and I have discussed it, but I think where we found what may be this ongoing question mark in people's minds is, number one, the definition of either medication reconciliation or medication recording, depending on who you're trying to satisfy. You know, what is the definition? And so what is our definition of what someone can do? And recording needs to say, means writing it down and then asking the patient if they're taking it. And I almost think it has to be kind of that clear.
You got to delineate between, you got to delineate between medication review versus medication reconciliation, which is more intense. It inquires, you know, how long you've been taking the medicine, who's been prescribing it, have you had any issues with it? But the reviews tends to be just based on what the patient tells you, and you're acknowledging, or you know, they're either being adherent or they're not.
Yeah.
And
I'm sorry. I was just going to say that in practice, you know, when I've been practicing myself and the PTs, we just do a review. Like the PTs will go over, you know, are you still taking this? And they'll have that in there. And then me as the PTA, the only thing I would ever do is, like, if the patient came in and say, you know, I stopped taking this, or the doctor prescribed me this, I would make sure that that was documented and, you know, let the PT know that it had changed. You know, and then if patients had questions about their medication, most times, you know, my scoped answer would only be just to clarify what they were taking it for, and then tell them if they had any further questions, they need to talk to their doctor or their pharmacist, because they're going to be the ones that can answer anything more specific about it. That their therapist doesn't prescribe medicines, and we can't answer that for them.
And then what about providing them some kind of written information about their medication? Is that in our scope? And I see Teresa shaking her head.
No.
I don't think so.
No.
Dr. Garcia, would you agree with that?
Well, the question is, if you're going to provide, are you going to be willing to back up your answer? Because a patient will hang whatever you say because you're the healthcare provider sometimes.
Right.
You know, and so you really got to, I mean, sometimes certain knowledge imparted to the patient can be detrimental also. You know, for example, if someone is going to have tissue plasminogen activator because they're having a heart attack, but you have to tell them the risk of that is cerebral bleed, and they hang all their fears on that very low percentage of cerebral bleed, and they make a decision based on it. And I've seen it happen where, so it's almost, you got to be prepared to answer those risk factors. And again, they're just, some of them are very minute, because in reality, you've seen it, it's very rare, but you still have, as a physician, you've got to explain or give true informed consent. So the question is, are you ready to give informed consent? I mean, you can, but then sometimes, you know, you can look at a list of medication, and probably the most common side effect for all medications is nausea and vomiting. Well, you know, I'm just saying, you know, so, but some could be, you know, people could have severe leukocytopenia. Okay, very rare for certain medicines like Clozaril, or it's very rare, but you still have to tell them. So you just got to be prepared to answer those questions.
Yeah, and that's not part of our scope. I think.
And I think just even with looking at my own parents, they hear a commercial and then there's the disclaimers at the end, and I get a phone call from my mother. This medicine I'm taking, they said it might cause me to die. Should I stop taking it? And I think we would be opening up a huge can of worms. I think it's always safer to defer to pharmacy or, you know, medical.
Okay. So,
oh yeah, I mean, technically any medicine can cause you to die. I mean, it depends if you have an anaphylactic reaction to it, right? I mean,
Right.
But you know, if we somehow cause somebody to change the way they take a medicine by their misinterpretation, then we're at risk, and I think we're practicing outside of scope. And so it's
Yeah,
better to leave it alone.
All we need to be doing is recording it, recording the changes, and notifying if it's home health, making sure the nurse in charge of that case is aware, and then the patient goes back to the physician or the pharmacist or the home health nurse with any questions.
I agree.
Probably the question that in home care, there can be patients who don't have a nurse.
Correct.
And that's probably what's driving it, is because there is some kind of issue, and home care is the provider, and it happens to be a therapist. So, they may not necessarily have the fallback plan other than to tell the patient, well, access your electronic medical record and you can have all the same information I would do, or call your pharmacist.
Well, I think if we're in there under physician order, especially for home health, then we would most appropriately just notify the physician's office that there's an issue with the medication or question with the medication. If a nurse isn't available, or if we can't get orders for a nurse.
But I'm not sure we should be the one contacting the doctor. I think that puts us in a position of liability. And so I think it's the patient should contact the doctor.
Yeah. You actually have to tell the patient that, because I think, again, if you're going to add that task to your duty, and if you forget, because we're human, then it's going to be put on you. I mean, I've always, when I have a patient who's seen another provider, unless I feel it's urgent, I'll call the provider, but I'll sit and really encourage the patient, and also to, make sure that they're aware of what they're taking, but just really put it on them, saying, listen, you need to contact your oncologist about this, because this potentially could be an issue. And a lot of times, most of the times they do that. If I don't, I'll tell the patient's family and document, spoke to the patient, spoke to the family. That's what you do. And that really encourages the patient to become a more activated patient. Patients who are activated, it's a term we use in digital health, they tend to do better. They actually, they have better health scores. So you really encourage the patient to be their own advocate, as opposed to being a passive patient. And a lot of times you can, at the next meeting, say, hey, did you get up with your doctor? And a lot of times most patients want to satisfy their healthcare provider. Oh, no, I didn't. So you kind of, you probably need to get up with them again, and you document again, spoke to the patient again.
Playing devil's advocate here. So let's say we have a pleasantly confused patient with dementia and not really good family support. If we have knowledge that they're not taking their medication correctly, are we?
Well, that's a different. I'm assuming the person has capacity. Now that's a different story, because if you don't think the person has capacity, then it would be upon you to either tell the family member, and if you really don't think they're dependable, and sometimes that does happen, then you have to at least call the provider and say, just be aware of that. But again, most patients have capacity.
Right.
And I'm going to throw out another thing. In the new education, physical therapists are not experts, but they all take a pharmacology course. And a lot of them, like in the geriatric scope of practice, knowledge of the more common medications is expected. So when we're doing certain things like taking their blood pressure, then if their blood pressure is high, of course, did you take your medicine this morning? And if they didn't, I've had to send people home before they're not safe to exercise. I mean, there is interactions between what we do and their medications that has to be discussed with the patient. So leaving in room that physical therapists might be discussing the medications effects on their therapy. Like, for instance, the patients on beta blockers have to tell them you can't use your heart rate necessarily, or sometimes to judge how hard you're exercising, because the medicine you're on is not going to let your blood pressure, your heart rate go up. So instead, you have to use the perceived rate of exertion. or something like that. So there is some interactions that we got to be careful not to restrict therapists from being able to use that.
I'm not really proposing changing our position statements significantly, but adding a little more clarity to what a PTA is able to do, because that seems to be where the questions are. And I have to say, I needed to have this discussion with the board before I could even come up with a recommendation about how we might change it. We don't do this very often, but sometimes after the meeting, we come up with draft language and then we send it around to everybody for their approval after the meeting.
So now, if you had to, as a PTA, if I had a patient that I was working with and I have to review their medications, I can write down the medications that they're on. And if they say to me, okay, what is this medication for? And I say, this is a blood pressure medication. And they got the other medications, that blood pressure medication. Then they come up with the question, well, why am I on 3 blood pressure medications? Why do I take this one 3 times a day and this one 1 time a day? Now, that's a question that they need to take to their doctor. I can say, this is a blood pressure medication, this is a blood pressure medication, but now why you're doing this and why you're taking so many and what this one does compared to that one, that's when I say that you need to take that to, you need to ask that question to your physician, but then I document that patient, that I talk to patient about what the medication was for, but told the patient to talk to the physician about the reason that they were taking that many medications. So it won't come up that Pearl said.
Right.
And you also got to remember too, not all, just because the medicine is indicated for a particular issue, it could also be used for off-label. For example, prazosin is a blood pressure medicine, but it's also used for benign prostatic hypertrophy. And it's also used for PTSD to treat nightmares.
Wow. Yeah.
I would go and if they have those type of questions, then those questions still should be referred to physician, but I also need to let the PT know that the patient are concerned about the medications, so that if they need to go and talk to them about something, then they can. But it's off the PTA to say, oh, this is this, this is this, this is this, and this is for this. You know what I'm saying?
Mm-hmm.
I think the only thing that needs to be really clear is that you cannot prescribe medications and you cannot reconciliate to tell the patient that you can take it or not without the doctor's approval. Even if it's a home remedy, I think needs to have the doctor's approval. But I guess we can explain any patient what are the medications for or whatever it takes, just not to get your name saying that you prescribe that medication, because that'll be the problem.
Or that it's misconstrued that you told them to stop it.
Exactly. No reconciliation.
Yeah, well, I mean, I say that because, for example, years ago, there used to be commercials from law firms trying to promote a lawsuit for certain medications. I remember when risperidol, which is an antipsychotic, was being, assaulted, and patients were stopped taking their medicine, and then they would decompensate and come to the hospital. And now you notice that some of the commercials now state, do not make any changes to your medicine without talking to your provider. So I guess the thing is, really emphasize that any change in or any intervention that it's not misconstrued, because a lot of times patients will only hear what they want to hear sometimes, or they may misconstrue what you say, and they'll say, oh, well, the PT told me I don't have to take this because it makes me dizzy. And I'll swear that's what you said.
Yes, I think the North Carolina, at least is the way I see it from just living for 25 years. I think it's getting diversified. And, for instance, in Mexican culture, we use a lot of home remedies, and we have the tendency to quit taking medications if the neighbor told me that I should quit the medication. I mean, it's a lot of lack of education. And I think that's when we need to educate the people that doesn't know the rules, and tell them, go back to your doctor, go back to your doctor, if it's any questions about it.
Okay,
Yeah,
so, oh, Scott, go ahead.
no, I've in my experience, I've had patients who will stop medicine because a family member or a neighbor, like Rosa was saying, a neighbor told them to stop it, and then there's some deleterious effect. And I always tell them, if you have an issue, just give us a call. Especially now with patient portals, I mean, I would encourage patients to actually send a question, and by the end of the day, they have the question answered back.
Mhm.
And now me working in public health, and I notice the people get surprised why, like, immigrants don't have a doctor, and that's a cultural thing, right, Dr. Garcia? Is we in Mexico don't have a regular doctor. You go to the doctor only when you're really sick, and you don't have a family doctor that you go regularly, and prevention medication is not in existence because of the economic issues. Only privilege, I guess, population that has insurance or whatever. But that's when I think I'm telling you, there is education. We need, when you treating people like immigrants or in that group, I think you need to be careful, because also in my culture, if I go with you referred by the doctor, I don't know what is your scope of practice, but whatever you tell me to do, I'm gonna take it literally, because you are in Mexico, they don't even explain you what they're gonna do to you or what you take in this or that medication. You trust 100% whatever your doctor is telling you, because it's for your own good. So that's what I have to say.
Thank you. And thank you, everybody, for contributing to that discussion. For me, that was very helpful. And what I'm going to suggest is that I come up with some alterations or edits or amendments to our current position statement, and then I'm going to send it around after the meeting and get your input for it, and then we can, once we get that approval, then we can repost it and I can answer these questions that I'm getting about it.
Okay,
Sound like a plan?
sounds good. Thanks, Kathy. The next thing has to do with over-the-counter medications.
Yeah, and I don't know that we can fully discuss this today, but I wanted to bring this up to you because, and I think Rosa's point kind of nicely segues into this. And that is that I have gotten questions in the past about over-the-counter medications. So we've already addressed the whole CBD issue. Well, apparently now Voltaren has become like a cream and can be purchased over the counter. And so to me, it still says over the counter. And so I provide our typical position statement. And, it's, again, it's not within the PT scope of practice and it should be used at your own risk. Well, I went back and forth on email with a very experienced member of our profession who really wanted to debate that and really wanted a further definition about, what I said was PTs do not prescribe medication. And that's part of this issue. And secondarily, because of that, we can't condone just using anything that you don't know what's in it with a patient. It comes down to, it's the patient's risk if they want to use that, and it's your risk to take on using that with the patient because they want you to. And, she felt like we were being a little too conservative and wanted a little more clarity around that. And I don't don't have any issues with wanting more clarity about something, but I guess in this specific instance with Voltaren being a previously prescribed medication and now it's over the counter, it's almost like, well, it should be okay to use because it's now over the counter. And I don't think that as a board, we're at the point where we can change that, nor do I think that we're at the point where we can define anything further around that, because I just don't have enough information to bring that up to you. But I wanted to let you know that I'm getting those kinds of questions. And the only plan that I had was to talk a little bit to Jay Campbell at the pharmacy board about it, to see if Jay had any specific language that I could use to help people understand, sort of the divide here that in regulatory authority, we don't have regulatory authority over the counter medication, and that kind of thing is really not taught in education, and it seems to be the Wild West of practice to use over the counter medications, and it's not physical therapy, so don't bill it as physical therapy, and if you're using it as part of your care, it's not physical therapy, and that's really not any different than what our current position statement says. So unless someone has some different insight or has been exposed to some of this or heard about it at continuing ed or something, I'm bringing it up because I'm getting those kinds of questions and they're very challenging to answer.
Well, I think you just got to be mindful that just over the counter does not necessarily mean safe. I mean, there's a lot of medicines that in the past were over the counter and are prescribed and now over the counter. I mean, you're still, if you ever read the safety profile for a lot of over-the-counter medicines, they have certain certain recommendations that you've got to follow too. So, for example, they may ask you, if you're pregnant or if you've taken monoamine oxidase inhibitors, things like that, that you just don't start popping pills just because it's over the counter doesn't necessarily mean it's overall safe. And there's still certain guidelines you got to follow.
Yeah, this was a gel that you want to use with ultrasound, and and then it's like the statement is, well, we all know that this doesn't penetrate very far into the skin. Well, I can't say anything about what it might mean for a specific patient, and therefore it's at your own risk, and that's about as much as I think the board can say.
Well, and I can tell you in outpatient practice, we were using Voltaren phonophoresis for years when it was prescribed by their orthopedist.
Yes, and I think that's the problem, is that because you could do it that way, and now that it's over the counter, they think they're being told no. And so where do we land on that? I think, Paul, you were going to say something else.
Well, I mean, and I wasn't aware of Voltaren being used as phonophoresis. I mean, I was just, my point being is that just because something, I mean, are they asking for another avenue to dispense the medicine besides the phonophoresis or iontophoresis? Or I guess that I've never heard that before.
Well, I think the question is pretty generic. Like, can I put anything in my iontophoresis unit? Can I use any kind of gel with my phonophoresis unit? I don't think the board has any ability to say that. And that's just the difference between regulation and maybe advocacy or best practice in the clinic. We don't have authority over medications, and if it's not prescribed for use for a patient at this point, that's what it says in our position statement. It needs to be prescribed specifically for a person, kept individually for just that person, and that's it. And I think what's being asked of clinicians is people are coming in with their little package of whatever, and they would like to use it as part of their care. And And so it's not physical therapy. And if that therapist wants to use it with that patient and they want to do it and they want to take on that risk and the patient wants to take on that risk, that's what we're telling them. It's your risk. It's not PT. And you really shouldn't be billing it as PT or calling it PT.
Yeah, I think sometimes we think if it's delivered transdermal that it's more safe, if you will, but not necessarily. I mean, if you live in Eastern North Carolina, if you ever pick tobacco, if you don't wear those gloves, you get all that nicotine in your skin, and it can make you not feel too well. So I think that's the concern. You just got to make sure that you don't want to fall a lull or at the wheel thinking just because it's transdermal, it's a safer mode form of transmission, because you still got to be mindful. I mean, fentanyl is a great example. You've got a small amount of gel that can actually stop someone from breathing, but it's delivered transdermal. I mean, that's why when we prescribe that particular medicine, we have to make sure that we start very low, make sure the patient can tolerate it.
Okay, well, and I am appreciating, everybody's comments on that. I think I don't see a need to change this position statement, but in case it comes back around, I'm just letting you know the kinds of questions that I'm getting. Very last thing, I didn't realize I had put two things about the same topic about the PTAs and medication, but the last thing is we're getting questions about students being able to do dry needling on clinicals. And that is because apparently 3 programs who have remained nameless as part of this question are actually bringing in continuing ed providers to do a full-blown course in their curriculums. And so therefore they want to know if the students could do it. This is one of those areas that I've discussed with David Gadd. We have determined that needs to go to our task force. And that's what I'm going to recommend about this one, and then let that task force come back with some recommendations. So we won't be able to answer that question at this time for the question askers until we have some further clarity about it. And so that's that, unless anybody has any other comments about that.
I'm just curious what the group thinks.
Absolutely not.
Okay, well, I'm just curious.
As a clinical education site, there is no way I would put my licensed therapist at that level of liability. No way.
I agree with Teresa. I mean, I was reading through this and I was like, ugh. I mean, I would not knowingly allow one of my clinicians to do it. They could demonstrate to the student, obviously, but I would not put a needle in a student's hand.
No, they're not a licensed PT. They've had an introductory course, level 1 course in school. No.
I agree with you both, but the only thing I know that other practitioners who have just crossed that line from student to graduate and also had that same entry level course are now dry needling.
And I think that's a little different since they've graduated, but if the question is about during their clinicals.
I asked that only because I know as when I was a medical student, you weren't a licensed physician at the time. And hold on.
Station break. When he comes back, could I make a recommendation that we take a
sorry.
break
I'm sorry
Okay.
about that.
Okay.
My young daughter decided to grab something from the room. But anyway, I was saying as a medical student, you were watched and you would do central lines. You would do thoracentesis. Mind you, the resident was there with you, but we did that as a medical student. And a central line by far is way more risky than dry needling. I mean, you're talking about injecting a long guide wire inside a femoral vein, and which could cause potential, but of course the med student also has malpractice insurance too. That's part of their package when they go during their training. But that's why I was just curious how y'all felt about that, because I know in medicine, that's almost, it's encouraged to actually teach the medical students that, make sure that they're comfortable, because when they get out in residency, which will be not, either within a year or within a few months, they're going to be expected to do those things independently.
So if I can add into this conversation, as part of analyzing scope of practice questions, one of the questions is, at what point does it become, quote unquote, routinely performed in practice? And so what I've learned about that is, either you practice it as part of your clinicals or your student education, or it organically evolves from someone who's coming from another jurisdiction, doesn't realize that it's not part of the scope here, and then starts doing it and their colleagues start doing it. Or, I know a hospital system here where the athletic trainers and the PTs work closely together. Athletic trainers can do it, so the PT started doing it, but it really wasn't part of PT practice yet. So this is how it evolves into routinely performed in practice. My concern here is that because we have what is determined already to be an advanced level skill that we've kind of said is beyond entry level, we are having some increased level of complaints with it. We haven't established for our licensees what our real risk tolerance is and what additional things need to be put into place. And so answering the questions about a student might be premature at this point.
Or we could always hedge our bets and say, at this time, we do not support students doing dry needling during a clinical, because their clinical instructor may or may not have ever done dry needling, or may have only had one entry level or 2 level courses, or a 3rd level course. I'm not comfortable letting that go out there.
And mind you, when I was when I was mentioning about the med student, the residents have done the procedure numerous times at least. I mean, so it's not like that is a good point. I mean, they've actually been trained, they've done it on complex cases, and they also have to feel comfortable. They may not feel comfortable for the med student to do the procedure if they don't have confidence in the med student to do it. So, because there's an old dictum in medicine is that you see one, do one, and then you teach one.
Yeah, I'm wondering, I mean, so you mentioned 3 schools, but we would need to know that most or all schools are teaching it.
Yeah, that's a good point. I mean,
and we're just, to me, it's kind of a answered question already. It's just the way that our statement is written now. It is, as Kathy said, an advanced skill, and I know students have to learn it, but with the history of this whole issue, I think would be jumping too far ahead to say, yeah, we bless this. And I think it's just too much risk.
Okay. Kathy, do you have enough information from this discussion to move forward?
I do. Yeah.
Does anybody else have another comment? Hearing none, would you all like to take a 10-minute morning break?
So moved.
Yes.
Okay.
So put yourself on mute, and if you can turn off your camera if you want to. But
so it's 10 o'clock. Everybody be back in 10 minutes. 10:10.
Dr. Garcia, a few years ago when like Good Morning America and all these news shows did stories on the risk of certain fractures if you were taking bisphosphonates, all these patients stopped taking them and were calling, and one of the doctors said we had to convince all our patients that the risk of those like femur fractures was much more rare than your risk of bone fracturing without the medication. But it was the same thing. And that was a big news story that everybody just said, hey, I got to quit.
Yeah. And I would always tell my patients, you know, to talk to me before you make any changes, unless it's, you know, I was just going to say about our previous discussion, it's interesting just because we're talking about like physicians that were trained maybe 20 years before I was. I mean, they actually had more reign as far as med students and residents. And also depends on where, if they were trained, if they were foreign trained, a lot of times, like for example, if you didn't have the luxury of having a phlebotomist. I mean, you actually, as the med student, went to do the lab draw. You know what I mean? It wasn't like it was readily available. And the other thing I was going to say, and when I say about med students, it wasn't like the Wild Wild West. I mean, we had very strict supervision, but I get a point being is that they wanted some hands-on teaching for the med students, because again, within whether it's a year or 2 years, you're going to have that MD behind your name, and even though you are a resident, you still were responsible for that patient.
Yeah.
And it happens pretty fast.
It's a double-edged sword, I think. And how else do you get that hands-on experience without having it? And I think, you know, when they did the HOMRO study about dry needling, that was what was missing from entry level, was the hands-on part. And so you have to get that somewhere else.
And Dave had a good point. I mean, if it's being taught routinely everywhere, and you know, for example, suturing is taught, at least, you know, to med students, even if they're not doing primary care. Even if you're being a radiologist, I'd be shocked if you aren't exposed or you do a few sutures as a med student or deliver a baby. You know, it's just, you just have that, it's there because you always see it. So those are procedures that have been around for years. They just might have been modified differently, but it's, you know, still. I remember when I delivered my first child, and when I was a med student, and it was 3:30 in the morning, and wow, it was fast. I was like, whoa, wait a minute. The resident was actually at the ED, and I was like, he was telling me how to do it. I was like, okay. So
you didn't have time to think. You just had to.
No. I was already cutting the umbilical cord. It was that fast.
Wow.
So, but I had the experience, and granted, it was 3:30 in the morning. But you know, when a baby's coming, they're coming.
That's right. That's right.
Okay, it's 10 after 10, so let's resume our meeting. Kathy, let me give it to you to reorient us on the agenda.
I think we're going to jump back to number F, letter F, closed session. And let me just count 1, 2, 3, 4, 5, 6, 7. We're missing someone.
This is David Knoll.
No, never mind. I'm sorry. Yes, David.
I just want to make sure before we go into closed session that I get the signal to kill the live stream, because that's really what's going to be the marking point for us going into closed session.
So, oh, I remember we were going to do that right before lunch, because often that's where that falls, isn't it? All right, so David, you know what? We're gonna, let's do the executive director's report and then Teresa, would you like to break at 12 for lunch today?
Yes, we'll shoot for that, depending on how long this takes.
All right,
If it's 12:30, I'm okay with that too. So
okay. So
you
what
want to
we'll
go ahead
probably
with the executive director's report? That would be letter what?
G,
Okay, so we would direct the participants of the board to go to G on the agenda and anyone listening in. Go ahead, Kathy. Thank you.
all right. So David Knopf, just to say this to you, the signal is going to be when the motion is made to go into closed session, and it will probably be closer to 11:30.
Right.
Okay.
Understood. Thank you.
Okay. Executive director's report. As always, if you have any updates or changes to your contact information, particularly the email and phone, that is important information, and let one of the staff know that you need an update to the address list, and you can click on the link and the attachment to see what we have currently for you. But if you're not having any issues with that, that's just there for your information. The licensee count, as of when the licensee count was last done, we've got 3.36% growth, which is a little more than the last quarter. We had a big exam, set of exams. And so, it's hovering around that 3.5% growth, which is probably where I think it's going to stay now. We've got back to 21 programs. They're all staying pretty stable in terms of numbers of students. And so, if people are continuing to choose to stay in North Carolina, it's going to be about that, a little less, a little more. The NPTE failures are there for your review if you care to review those or want to look at that information for other reasons. The first item that we need to approve and do a possible motion for is for the fiscal year of 2022 goals and priorities. And you have that attachment there. The updates and new goals for the fiscal year of 2022 starts on page 2. And, that's in your packet. So I'm not going to review each individual one, but we try to provide information about what is in process, things that have been completed, have been removed, and we've added new things. The only thing that I did not add to this that needs to be added is under information technology, and that is a real focus on cybersecurity. Given what has been going on in the world with ransomware and other hacking issues, that has to become front and center for the IT department, and Greg's going to provide some information about that a little bit later. So that would be added to the board performance category. So that would be the only edit that I would have. And then I would ask for any questions or if you have any comments, and then we'll need a motion to approve it.
Kathy, does the board office have an insurance policy for data breach or ransomware or any of that sort of thing?
Well, we purchased a policy a couple of years ago through State Farm. It's a rider to one of our current policies that is $50,000. So given what Colonial Pipeline paid, that's insufficient for what a potential ransom would be. But heard a great story the other day about how someone negotiated with one of their ransomers. And regardless, what the IT department is doing, I'm not going to explain that to you. I'm going to wait and let Greg explain their actions and what the plan is should something occur. But we have a minimal policy in place. At the time when we looked at the insurance, we went to our directors and officers insurer, and it was going to be some outrageous amount of money, you know, maybe, I don't remember exactly. I'm going to guess $10,000, because as the broker put it, it was the wild, wild west of insurance at that time, because they just didn't really have a sense about what the risk really was. And so, you know, now I think we're getting a better idea about what that potential risk is. We do not keep information that is there. We don't keep any financial information from anybody on site, you know, and so we have some information that you would not want out in the public domain. But what I will say is my understanding is that these are bots that are doing this. And so it's not a human being looking at your system to go, oh, I like that information and I'm going to take that, or we want to target them. You know, it's somewhat random, and they're targeting small places. So, you know, the risk is as high as it's ever been, I would say. And so we've got some coverage. And that's going to also dovetail into our financial discussions about why I'm making certain recommendations about keeping the amount of reserve that we have. So hope that answers your question.
Thank you. Has everyone read the goals and priorities on recommendations for 2021 to 2022? And do you have any further questions for Kathy? You have the goals and priorities in front of you. Do I hear a motion to adopt this policy, goals and priorities?
So moved.
Second,
David has made the motion. Who was the second?
I did. Pearl.
Pearl. Okay. Motion's been made and seconded, David and Pearl. Is there any further discussion or questions of the executive director about this? Hearing none, let's have a vote on the motion. All those in favor, let it be known by saying aye.
Aye.
All those opposed? And is anyone abstaining? The motion carries. Thank you for all the hard work and the report, Kathy.
Welcome. Moving on to the next agenda item, we have summarized for you the state of emergency regulatory flexibility actions that the board has taken. And that's in the attachment, the first attachment. Oh, no, I'm sorry. It's the second attachment. Hang on. Yeah, and there's a table there. And what I would like to do is just review these. When this was written, it was pretty early on before the meeting. And so there's a few adjustments I need to make, and there's a little bit of duplication. But what we need to do is review this with the thought in mind of when the state of emergency ends. Will we continue with the same changes that we've made, or will we go back to something else or something different? And we've made some recommendations for you. So the first item is exam eligibility, and basically we voted to move to the AAP process. In order to do that, we made some temporary board rules, and we're in the process of making those permanent. So you'll make a vote on those rules a little later in the meeting, but we are expecting that we would continue with making those rules permanent, continuing with the AAP process. Just to remind you, that means FSBPT approves all CAPTE accredited education students for the exam. And they do all special accommodations, and the board continues to make eligible for the exam special foreign trained students. So I'm going to ask the question, would everyone agree that we would continue with this as recommended, continuing with AAP as recommended? Okay, I got 1 thumbs up.
Yes.
Yes.
Awesome. 2 thumbs up, 3, 4, 5. Good. Okay, so yes. So continue. All right. The next item is FBI criminal background checks. The alteration that I would like to make to the recommendation for this one, we can continue to have self-inked fingerprints. However, it represents a little bit higher percentage of those fingerprints that might get returned because they're not legible. So what we're going to do is rework the paperwork to say the preference is go to a live scan, go to a UPS store or one of the other options, because they have machinery that can make these prints a little clearer. And if you can't, still use the self-inked fingerprints. But we would like to continue to offer those options to do the FBI fingerprints. They mail them to us. Those that don't do the live scan, they mail them to us. We FedEx them to the FBI. So we would like to continue with that. That's the recommendation of the staff. And anybody in disagreement with continuing with that plan?
Good.
Nope. Okay. Nobody disagrees. So we're going to continue with that. License verifications to and from other states. Those have gone electronic. And they are sent electronically, received by the recipient electronically. We receive them from others electronically. And the only little piece that we're still working on is sending an automatically generated email to the licensee, basically saying, we did this, so they've already been sent, and you need to be checking in with the other jurisdiction to make sure they receive them. So we're going to recommend continuing with that. Any disagreement? No.
Yep.
Okay. Acceptance of application documentation. So we currently are accepting graduation forms, which, used to be known as those assured graduation forms, or, graduation forms, transcripts directly from the primary source. So directly from the educational institution, and then character references, they can be emailed from the actual reference, not the applicant. And then one thing I'm going to add to the bottom of this list is that if someone has an initial coursework tool or an educational credentials review, we received a question from IERF, one of the, excuse me, one of the credentials reviewers. They have an online portal and they can send it to us that way, and we can access it electronically. So I would like to add that to the list, because my understanding is that we've been doing that as well, and we receive them electronically from FSBPT. So we
Kathy,
do that. Yes.
let me interrupt just a minute, just for the record. Will you define IERF?
I don't know what their acronym is, but they're another FSBPT approved user of the coursework tools, so they're a credentialing agency. We don't see very many from them, but they periodically want to verify with us what our rules say about what coursework tool has to be used. And I just responded to them, and then they said, oh yeah, and by the way, will you take this electronically? And my understanding is that we're already doing that from FCCPT. So the answer would be yes, but I'm recommending that we continue with these plus the coursework tools.
Okay, great. Thank you.
All righty. Foreign trained applicants. As you know, we've run into some situations with those who have been educated, many years ago, and the original copies of their educational credentials reviews have They don't have it anymore. The institution doesn't have it anymore because it's been record retented. And so if they have a copy that they can have notarized, we are accepting that. And then similarly with TOEFLs, there's a whole process. They have to prove that everything is missing. We don't just accept their word first thing. They have to demonstrate that another jurisdiction doesn't have it, that the original testing institution doesn't have it. And then if they have a copy, we may be willing to accept a notarized document. So we're recommending that we continue to accept that. All right, no, hearing no objection. When the state of emergency ends, the board will reinstitute the 1-year expiration of the application. So that triggers that they would not only have to reapply after a year, but they would also submit the reapplication fee, because then we're doing all the processing again. So that will be one that does change.
Yes. Just going back to the way we used to do it.
Yeah, and that's somewhat for consistency and stale applications, because it's often really challenging for the staff to make determinations about, is this application too stale to continue to process? So we'd like to go back to that. All right. License renewals for, this should say 2022. That we will continue with online payments. We will no longer use e-checks. That resulted in us paying fees that were unnecessary because the e-checks were bouncing, and it wasn't because of insufficient funds. It was just an entry, a number was entered wrong or something to that effect, and there was a lot of extra staff work required for that. So e-checks is not the most efficient way. We're going to go to credit cards, period. And we'll continue with the same, all renewals online. We had changed that last year and worked very well. And then we're working on developing an online revival process. We have not yet done that. Really, we're working on taking everything online. In addition, the ways to pay for it. So we're just continuing on.
And that's credit card or debit cards, right?
Yes, either one of those. As far as collections of fees and costs, again, once the state of emergency is lifted, we will return to reapplication fees needing to be paid. We still don't have an online portal for paying for costs of investigation. That's being worked on. We are no longer charging for licensee lists, and the metric for whether we're going to charge for those or not is only if the programming required is greater than 30 minutes. And then we would use what's in the fee schedule. So we get very, very few of those. So as long as there's no objection, we'll continue with that. And we will return to non-refundable application fees, unless there are objections. We're going to talk about it more during the financial portion. Consideration for reducing the 2020 licensure fees by $20. We'll talk about that more in a bit. And then we'll do whatever decision there is based on that. We will continue with no examination retake fees, and the rationale behind that is with FSBPT doing the approval for exam taking, we're not doing the work, so it doesn't justify a cost. Once the state of emergency is over, all temporary exemptions from licensure. We've already prepared letters. They're going to go out hard copy, and they're going to go in email, letting them know that they no longer have privileges to practice. And if they would like, they can obtain them through a compact privilege or a license. As a sidebar, yesterday, we got a couple of reports from CAPTI, and we've had about 40% turnover in program directors in the state. And so it just happened that Debbie looked up one of these new program directors, and we didn't see her. She didn't have a license, and but yet was using PT behind her name, et cetera. And so I emailed her, and it's a little, you feel uncomfortable on some level with someone that you've never met, who all of a sudden you're telling them that, or they could feel like you're telling them that they're doing something wrong. And she right away sent back an email that said that she had a temporary exemption. And I said, oh, that's great. I forgot to look at that list. And I said, just so you know, that's going to go away when the state of emergency goes away. And so, like right away, that prompted her to, start her licensure application, which, so I think these things are, they've certainly been useful and valuable to keeping the schools with program directors, but they need to use the licensure path after that's over.
Just on a quick question on that.
Yeah.
Like in our database, we have that list who are on that temporary licensure. Would it be in our best interest to maybe just send them an email saying, hey, to be prepared when the executive order lifts, you will need to go through this process?
We've done that.
Okay.
Yeah. And then that gets stale over time because, the longer
Right.
this goes on, you just don't know. But yeah. We've got that almost ready to push a button and send it when the time comes, for sure.
Okay.
And they were notified of that initially.
Right. But, just, for them to be thinking about, because the time is probably going to be coming in the next couple months. And
I think we don't really know. I think that's the
Yeah.
trouble, is because we don't know. I've heard anecdotally that they may not be lifting it because we need to get through the fall flu season. And are we going to have another resurgence, and so I feel like chasing around speculation for what the governor's going to do is hard for us to do.
Yeah.
Then we're sending out 300 notifications, routinely, which
Mhm.
people don't often read. So I don't know. I think we can periodically do that. So when the board returns to, or when the state of emergency ends, the board office will reopen to the public. Work schedules for staff will change to 5 days a week. Those that were working 410s will change back to 5, and depending on the supervisor, they will make determinations with the staff what each person's schedule is. We'll talk more about specifically what the office will do in just a minute, but you've provided me the authority to make those decisions. So, but that's the plan at the moment for opening the office. I think the board has already made the determination that looks like we'll be returning to in-person meetings in September. And so those have already been pre-scheduled for the conference room downstairs for December for September and December for 2021. Barring anything unusual happening, investigative committee has also made the decision that it will return to in-person meetings, and we're going to meet at the board office.
And
any of those can be changed. Yes.
Chime in on the board meetings. The session law that was passed to allow us to meet in this way and stream the meeting via YouTube also expires when the state of emergency is over. So we would be forced to revert back to the way it was when the state of emergency expires.
Okay. Good to know.
Okay. We've been continuing to provide reports to the state and any additional reports that they've required. So far, we have met all of those requirements. I haven't seen any other new ones lately. So I think we've met our, especially the one regarding regulatory flexibility, we've met those obligations. There's some new information in our annual report that we have to file, but that's not until October. Yeah, this next one is a duplicate notification of all the temporary exemptions from licensure. And then we've already addressed the question about vaccinations. You know, PTs can do them with appropriate training and supervision and meeting any other state law requirements. It's just not part of the PT scope of practice. So we will go with the recommendations that are in this document. Thank you for helping me review that. I believe the only one that we have to make rules about is to finalize the AAP permanent rulemaking in order for us to be able to do it. Then a little bit more about the office and some changes that we're going to make. I do need a motion for this. I am recommending that in the employee personnel and policy manual, it currently allows for comp time for exempt employees, and that's really not allowed by state law. It's rarely, if ever, used, and it's going to eliminate. So I'm recommending that we eliminate it. It's also going to eliminate the need for us to collect timesheets from exempt employees. The only reason that we do that now is if we ever were going to implement this policy, and it's not required by law, and it's time for us to eliminate that.
So Kathy, in response to that, could you explain exempt versus non-exempt for people who may not be familiar with that?
Well, it's a status. It's an employment status. If you are non-exempt, your work is more supervised and directed. If you're exempt, you may be a managerial level, or you're more independently functioning. And for example, all of the deputy director, director of administration, director of information technology, and office administrator are all exempt employees. Works more self-directed, or they supervise employees. Non-exempt are primarily licensing staff. We are currently reviewing David Knoll's status as a result of the fact that he is now needing to be a little more on call regularly and working off hours, which, you know, as a non-exempt employee requires then that you pay overtime. And I think, you know, where his job has evolved to may have evolved his status. We're getting an opinion on that from our HR attorney. So we'll see. We don't have that opinion yet. But legally, there is no comp time for exempt employees. You know, you get paid a salary, so your pay is the same every 2 weeks or month, or how frequently you get paid, and you know, your hours may vary within that, but you receive the same pay. Others are more hourly kind of work, or you have an hourly wage. So does that help?
Mm-hmm. Thank you.
Okay. Mm-hmm. We may have talked about this at the last meeting, but also in the employee policy manual, I'm reinstating the criminal background check for all new hires, whether they're employees or contractors. You know, this is a safety and security measure, and particularly with those that handle money or the security of our IT. It's important that we at least have an initial measure of you know, what we believe is safety. And as we return to non-state of emergency world, I've done some staff surveys and looking up some remote work policies, and overwhelmingly, the licensing staff would like to remain working at home. And I think with the leap that we've made from paper to electronic, that's working out really well. And as long as the board doesn't have different feedback or feels like, you know, there needs to be something different, I am recommending that they remain remote employees. There'll be, you know, a few job description changes, if you will. The technical requirements basically are that, you know, we will provide them with the computer and related materials, and that's a security measure. And then, but they will need to provide their own internet service, and that's. I'm sorry.
Excuse me. One thing I want to ask you about that is if they're going to work remotely from home.
Mhm.
I'll call the office number, or if I need like to talk to Kimberly or whatever, I can never get them. I can never get her. And I don't know her number to call and ask questions. So I have to go through text.
Yeah, we are still working on the communication scheme for that. We don't have that 100% figured out, Pearl. But that's something that needs to be fixed now. Debbie and I both have business cell phone lines. And so I will write that down as something that we need to address right now. Thank you for bringing that up.
Kathy, do we have any security concerns or IT concerns with the ransomware and so forth of potential, you know, weaknesses with the remote, or are we pretty comfortable with that?
Well, I'm going to give you the short answer now, and I'm going to say, I think we're pretty comfortable. However, will you please write that down and ask Greg, because he's coming on later this afternoon to talk about that some more.
Okay, thank you.
Yeah, but I think it's a great question, and it's important to ask it, and we need to keep asking it. They are actively doing some things to lock our security further, you know. Okay. So what I do need is a motion to approve the recommended changes to the employee personnel and policy manual, please.
So moved.
Thank you.
Second.
David has made the motion and seconded by Leslie to approve the updated employee policy and procedure manual with the inclusion of the elimination of compensatory time for exempt employees and the change of 4 10-hour days to the 5-day a week. All those in favor of this motion, please let it be known by saying aye.
Aye.
Anyone opposed, say no.
I need to amend the motion.
Okay.
And we need to include the FBI criminal background checks for new hires
Right.
with that.
And does the maker of the motion and the second agree with that amendment?
Agreed.
Thank you. Any further discussion? Okay, we'll take another vote. All those in favor of the amended motion, let it be known by saying aye.
Aye.
Aye. All those opposed, no. Anyone abstaining? The motion carries.
Madam
Okay.
Chair, can I say something real quick? I failed to mention this at the beginning of the meeting. This online way we're doing these motions under the new law requires that they be roll call motions, however, and roll call votes. However, when everyone is voting in favor, we don't need to go through the roll call unless there's, you know, there's some no's in there. So if you don't mind, go ahead and calling the roll. And then if there are differences in votes, we can sort that out. But that way we'll just be in compliance with the statute.
And do you want me to do that for every motion?
I don't think
Every
so.
vote?
If they're unanimous, I don't think we have to go through every one, but if you'll just, for the record and for the meeting, if you just call the roll now, I meant to mention that at the beginning of the meeting, but it will solve it if we go ahead and call the roll at this time.
Okay, let's take care of that right now. So roll call. Leslie Kessler, are you here? Verbally.
Sorry, I had to unmute. Yes.
Okay. Jimmy Minor,
Here.
Dr. Paul Garcia,
Present.
Crystal Osland,
Here.
Pearl Roan,
Here.
Rosa Gonzalez,
Here.
David Edwards.
Here.
And joining us in our administrative team is Kathy Arney.
I think you just need to do the board members.
It's just the
don't you?
board. Okay.
For the votes, yeah.
Okay. Thank you.
Thank
So
you
all
very
board
much.
members are present and accounted for.
Perfect.
Kathy?
Got it? Okay, so the next item is board meeting policy and procedure. Come on. That is not the document I wanted. I did upload some information previously about board meetings, and I see that I don't have the right one up there. I'm gonna add another one to click up for you. So that you can look at it, and it's a board policy about board meeting attendance. Okay, it's up, it's loaded there, and it's got a title that starts with board meeting policy. So if y'all would take a minute and take a look at that, please. So if everybody's had a chance to review that, this just puts a framework around board meetings and the attendance policy. And I think the board has never really had to face this situation before because we've never had a pandemic before. And based upon state law and the expectations of licensure boards and what our statute says, I created this memo for your review and adoption or editing, should you see fit.
Kathy, I'd like to ask your rationale on allowing 3 meetings, a member to miss 3 meetings without cause when we only meet 4 times a year.
It's in the statute. We can amend the statute, but I don't think we want to open the Practice Act for that.
The Practice Act?
And is that 3 meetings during your term? So 12 meetings total versus 3 a year?
I'm pulling
We
it
would
up.
need our attorney for that.
I can read it to you in just a second. It says and this is directly from the Practice Act. It says the board may immediately remove a member from the board if the member is found by the remainder of the board to, one, have ceased to meet the qualifications specified in this section, two, failed to attend 3 successive board meetings without just cause, 3, violated any of the provisions of this article or rules adopted by the board, or 4, otherwise engaged in immoral, dishonorable, unprofessional, or unethical conduct.
So 3 meetings in succession.
Yes.
I've amended my thing here to include that.
Do we need a motion to adopt this policy?
Please.
I motion we adopt the policy. This is Jamie.
I'll second.
Motion's been made and seconded to adopt the policy as written with the editorial change to reflect the language of the Practice Act. All those in favor, please let it be known by saying aye. Aye. All those opposed, say no. And anyone abstaining? The motion carries. Kathy?
Thank you.
It would be interesting to see how much money we've saved though over the year, 18 months of remote.
Well, we can probably
It
pull
seems
that up.
its cost purposes were supposed to be as economical as possible, but then we're prohibited by law from using that option.
Right, it's odd.
But that's what I get for trying to make sense out of the government, right?
Right.
I do think, I don't know if we can speculate, but, because of in part that reasoning, Leslie, I mean, there may be law that changes this some as long as you are enabling the public to participate, but I don't know. We haven't seen anything from the legislature about that yet because state emergency is still happening.
And I wouldn't be surprised a bit if the General Assembly adopted some new law allowing boards and agencies in the state to continue to meet in a manner similar to this, because people are used to it now, and it's got great convenience. So that wouldn't
Right.
surprise me at all.
Well, I think we're very fortunate in North Carolina that we have the option. I mean, that it's a reasonable distance for us to travel and do those types of things. And I think about other states like Hawaii or out in the Midwest, where their board members are so scattered. So we're fortunate that it's not too much of a challenge for us to do it in person. So
That's right.
Mhm.
We've already covered the elimination of the compensatory time. This next one is more of a FYI for the board, but I wanted you to see that there was a memo from the Attorney General that was sent to occupational licensing boards to basically say, this is law that you give people an opportunity to work. And here are the requirements around those with criminal record histories. And so we created a document in response just internally for us to demonstrate to ourselves how we had complied with this H 770. And we identified that there were 2 areas where we want to take another look. And that is posting some additional information on the website about those that have criminal history records and what what the application instructions need to be for those. And then
Kathy?
the appeals process. Yes.
I need to step away for about 10 minutes for a patient need. Will that be okay?
I think Madam Chair would be the person to be asking.
David will excuse you for 10 minutes.
Okay, thank you. I'll be right back.
So, and those will be a part of this website update that we're working on. And then the second thing is we do need to make a referral to the rules subcommittee to consider whether we need to make some additional rules about clarifying any reason for denial about licensure. And that came out of that law. So effectively, we are complying with this law, and we're going to enhance our website information and then look at whether we need any further rules as a result. So I don't think this criminal record history comes up that often for our boards, but I'm sure it does for others. And so this is an important memo for occupational licensing boards. I was invited by the FSBPT to attend the American Society of Association Executive Training Program. So I'll be doing that in November, and that'll be the first in-person meeting I've attended in a long, long time. So that'll be interesting, and certainly would be helpful to our board, whatever I can bring back and implement here for you.
And FSBPT is covering the cost of your attendance.
That is correct. Yes, they are. So that was a very nice invitation, and
Yes.
I am very appreciative. I expect part of that is because of the chairmanship of the Compact Commission.
Mhm.
And I have learned over the last 3 months how important the compact is to the Federation. I mean, I knew that already, but just, it's very important to them. And I think that they're trying to help leaders throughout the various groups that are associated with them to enhance their skills in whatever ways that they can. And then just again, an FYI, an updated report on exemptions, and this was added yesterday, just to give you a hint about, or a bit of information about the statistics. We have had 342 requests for exemption from licensure. And interesting, you think about that. What if those had all been licensees, or what if those had all been compact privilege holders? A whole different thing. So, we'll see how many of those really do convert once the state of emergency is over, because there are lots of people that it was pretty clear that they were performing telehealth in North Carolina, and it's going to be important that they continue to have a privilege in some way to practice here if they're going to continue to do telehealth. What another interesting aspect is that people were using that as a bridge because they were applying for licensure here already, and they could get here, practice more quickly with the temporary exemption, and then they went and gotten a license. So once they obtain the license, the temporary exemption is rescinded. So there have been 77 of those. If I'm reading Kim's document correctly, but so a percentage of these are actually becoming licensed here now, and we'll see what happens once the state of emergency ends. Okay. I think we can get through the financial report by 11:30. So when it comes time to make the motion, we will want the chair or the member of the Finance and Audit Committee can step in and make that motion. So thank you, Crystal. Hang on just a minute. I got to change documents. Okay, so my verbal update is that, we are in good shape financially. I will say that, as you expect, our expenses, for many things have decreased, with the exception of personnel. We've added personnel, and we have added contract personnel for the purposes of programming. And so that was all planned for, and we're making progress with having 2 programmers in place. So when you look at some of the financials, that's what you'll see. As far as income, we're about $30,000 ahead of where we were last year. When you look back at the number of exemptions, and if those had actually been licensees, it might have been more like 70,000. But that's just that's the way it worked. As far as our expenses, again, they're higher, but it's primarily a result of adding staffing. When you look at the profit and loss statement under the board, I'm going to say it's about half of where it was in the pre-pandemic world, or what we spent for board per diem and meetings. And so certainly for per diems, it's half. For meetings, it's essentially zero, because we haven't had the related expenses of travel and food and hotel. So, and then if you go to the balance sheet, this balance sheet was done as of May 5th. We have since closed a number of these accounts. It doesn't change the overall amount, but we have a total assets of $3,300,000, and that's about $300,000 more than last year at the same time. And then in terms of liabilities, we've got about $100,000 in liabilities. So, the net of that is about $2 million. And what I believe that this board needs to keep at absolute minimum is a 1 year in the non-pandemic world of expenses in the bank. And, on some levels, this is related to what if we have a litigation? What if we have another pandemic? What if we have a cyber experience? We need to keep the reserves high enough to be able to operate for a year and then incur whatever costs we might from that. So that plays into what I am recommending for the budget. And you had a lot of background materials that you could take a look at for that. Before I pull up the budget, let's talk a little bit about renewals for 2022. So we had said, as part of regulatory flexibility, that we would ask the Finance and Audit Committee to consider whether we should reduce licensing fees for renewal by $20 during the renewal for 2022. And after discussing it and talking about these reasons, we decided that the committee did not want to make that recommendation. So that was not put into the proposed budget. And the reasons are, as I just stated, we need to keep the amount of operating expenses in the bank 1 year. And then we need to be prepared for, some of these potential just risks of being a regulatory board. And if we were to reduce the fees, it's $280,000. And that's significant in having resources to continue to operate. So not making that recommendation. We also used data from the minimum data set of last year that we collected. As you may recall, there were a number of requests, why are we still, charging licensing fees at all? And, why are we still requiring various continuing competence requirements, et cetera, by people? And so I asked Greg if he would, he and Debbie worked on this together. He pulled out some of the information about whether people were working last year. And basically, the PTs seemed to report that they were working at about 97%, PTAs 89%. Interestingly enough, everyone, and because these were done in ranges in the MDS, it's really hard to say exactly how many hours people were working, but it was basically about half time. 25 hours was the average. So there were a lot of people that didn't answer the question. So it's really hard to say, but people were working, so they need to have the license. And I think what we were hearing was that, people had lost their jobs to a large degree, and that didn't bear itself out to be true with the fact that 96% of people renewed their licenses. And, if they weren't working and they could have allowed it to lapse until they were working again. But the data that we have just doesn't demonstrate that. So those things all combined, we're not making that recommendation. So let's look at the budget, proposed budget for 2022. I don't know if any of you are having difficulty opening it, but I'm having a little trouble opening it.
Mine opened okay.
You got yours?
Yeah.
There we go. I just need to move it. Well, I have a paper copy, so I'm going to look at that. I guess what I'd like to know, we tried to make this a side-by-side thing, and we went through a couple of iterations. Paula helped me with this, and I think what you're looking at in the column that is in black, it was the budget from fiscal year 2021, and the column to the right is the budget from 2022. So you can see, the differences in income and anticipated expenses. And I'll be glad to answer any questions that you have about that, or anything you think I didn't include that needs to be included.
On the income side, it looks like you've added 2,000 in there for discipline reimbursement. Is the investigative committee anticipating a more active year?
We had to obtain 2 expert witnesses, and as mentioned earlier, some of these questions or some of these complaints or the situations are becoming more complex. And there are areas of practice that I don't personally have experience, or maybe the other investigative committee member might not have experience. And we feel like we need some additional information and expertise. And so, we're paying for that.
On employee benefits, there are no line items for health insurance.
Let me get there. It's under 6711 group insurance health. Oh, I did this in aggregate. One of the things that is interesting about the health insurance is that some of these things renew at different times of year. And so I'm doing a lot of calculating, and I didn't do it as a line item. And I've accounted for all of the benefits, but I did it in aggregate. All right, our insurance actually went down this year.
Wow, that's remarkable.
It is, and I've heard that in a number of places, and I think I've heard that part of it was insurance companies were, and it might have been David Edwards that told me this.
Yeah.
Yeah, you could tell, Dave.
Yeah, they're only allowed to keep a certain percentage of the premiums. And so therefore, with less elective surgeries due to COVID, their profits were way too high. And so therefore they had to, you may have gotten a card if you're under some Blue Cross plans for $250 for wellness, but they also had to reduce some of the premiums to offset some of the increased profits during COVID.
And our staff did get those debit cards to go use like at your pharmacy for products, over-the-counter products that you might use. That was just part of our Blue Cross plan.
Well, United Healthcare did not send me a debit card.
Yeah, my company changed to MedCost this year. We didn't get anything either. We had Blue Cross last year.
Yeah.
Well, that means they met their med loss ratio then.
Okay, well, if there aren't any other questions, the chair of the Finance and Audit Committee gets the pleasure of making a motion.
Yes, ma'am. Having heard no questions, would make the motion that we accept the proposed budget for 2021, 2022 as presented by the executive director.
I'll second that.
So the motion's been made and seconded that we accept the budget as presented as in front of you from the executive director. Are there any further questions or discussion? Hearing none, are you ready for the vote? All those in favor, let it be known by saying aye.
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 All those opposed, please say no. And is anyone abstaining from this vote? The ayes have it. It's a unanimous vote to accept the budget. Thank you, Kathy.
And thanks to the Finance and Audit Committee for doing a great job, asking a lot of questions, made some adjustments, and thank you for taking the time to do that.
And thank you, Kathy, for digging and detailing and maximizing efficiencies.
You're welcome. That is totally a team effort for sure. I wanted to report that Cindy has diligently been working on the last pieces of our corrections to our payroll audit, and those are with the retirement plan. Those have been funded by both the employee, and the missed earnings were funded by the board as appropriate. And that is now complete, and we can take that off of the agenda. So we're finished. And I think we have a good understanding with our current payroll vendor about, what things need to be taken out, what things need to be taxed, and it done in a timely manner. And we will continue with that going forward. So thank you to Cindy for finishing that up. Our new payroll company sent us a nice summary report on their filing of our first quarter payroll taxes. So I'm putting that in to say that it's done and there are no problems with it.
Yay.
Yeah, yay.
It's good. It's next to impossible to pass those audits. There's always something. So that's excellent.
Yeah, I'm feeling good about having that completed. All right, so I think we're ready to jump back to the closed session. So,
Which is letter
letter F. Closed session.
letter F. We will need a motion to go into closed session.
And David, all this is your cue.
I move